Good afternoon and welcome everyone. My name is Chanel Moore and on behalf of Lung Foundation Australia, I'd like to thank you for joining us for today's webinar. I'd like to start by acknowledging the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them and their cultures and to elders both past, present and emerging. Today we are presenting a webinar on spirometry and understanding the role that it plays in managing your lung health. Before we get into introductions and into the presentations, there's just a couple of points I'd like to make first. The first one being that this webinar will be recorded, so if you need to leave at any time or if you would like to refer back to it as a continuing resource, you can do so, and we'll make it available via our website and let you know when it is available. A Q&A session will also be held towards the end of the webinar, so we really do encourage you to submit any questions that you may have, or if any questions pop up whilst you're listening to either of our speakers, please just use the Q&A box that you should see on your screen and submit your questions through. I'll then direct them to our speakers or a specific one if you would like it to be answered by either one. So we are very fortunate today to have not one, but two speakers with us. We have Ian Smith, a respiratory scientist at Prince Charles Hospital, and he's going to be sharing his knowledge about what spirometry can tell you about your lung condition, test preparation, what to expect, and what results can tell your specialist or GP. We'll then have Amanda Curran, our respiratory care nurse here at Lung Foundation Australia, who's going to be sharing some commonly asked questions that people living with bronchiectasis or COPD may have about spirometry, and also how she can support you as well. So I guess without further ado, I'd like to introduce you to Ian and invite Ian to share your screen and chat with everyone who's joining us here today. Thank you, Ian.
Thank you, Chanel. As Chanel said, my name is Ian Smith. I'm a respiratory scientist based at the Prince Charles Hospital here in Brisbane. And I'd like to thank you all for joining us to learn more about spirometry. Just before I start, I would like to thank the Lung Foundation for this opportunity to present this topic to you. As spirometry is a fairly broad subject, it can get quite physiology heavy. So I haven't delved too much into that, but if there is a topic that you're interested in, I should be able to answer your questions at the end. Now, I'm not sure if there is any healthcare professionals viewing this webinar, but I just want to remind that this presentation is aimed towards patients and improving their own knowledge of spirometry. For today, I'll just be going through what is spirometry, what does it tell me about my lung condition, and then go into what is actually involved in the preparation leading up to spirometry, and then also specialist has requested that you perform spirometry. But what is it? Well, spirometry is the most commonly completed lung function test performed at either a GP's clinic or at a respiratory lab and completed on a device called a spirometer. The goal of completing this test is to measure the maximal volume of air a patient can inspire and expire. So how much air can they breathe in and out? From this, we can determine if there is any airflow limitation that may be present. Now, spirometry is actually broken down into two tests: a forced manoeuvre, so a forced vital capacity manoeuvre, which is a forceful maximal effort test. Then there's also a slower vital capacity manoeuvre, which is a bit slower. It's generally unforced and steady. I will get to those in a moment. So, with a forced vital capacity manoeuvre test, it's designed to measure how hard and fast a patient can blow out after a deep breath in with maximal effort. This effort is broken down into three distinct phases. Initially, you'll be asked to take a maximal deep breath in, followed by a forceful blast out until you've emptied your lungs, before finally taking a maximal breath back in again. In saying that, some spirometers may not measure that final breath, but those first two steps are always there. Now, what this actually provides is a flow volume curve that shows the flow rising very quickly to a peak value before declining as time progresses. So you're blowing all the air out of your lungs and there's not too much left when you're finished. The most commonly reported measurements that are taken from this test are the FEV1, which is the forced expiratory volume in that first second. So it's measuring how forcefully you can blow out in that first second. The forced vital capacity, which is the maximum volume of air that is forcefully expired by the patient. The FEV1 FVC ratio, which reflects the amount of air expired in the first second as a general percentage of the total. And there was also the peak expiratory flow, PEF, and that is measured at the very beginning of the forceful expiration. So it gives us an indication of how strong and how forceful you can blow out at the very start. Now, compared to the slow vital capacity manoeuvre, it's a test that's performed in a more of a relaxed manner. It is designed to measure maximal capacities with a relatively constant flow. In healthy subjects, the slow vital capacity is going to be very similar to that forced vital capacity measurement. However, with certain airway diseases like COPD and bronchiectasis, the slow VC can actually be greater than what we obtain during a forced VC manoeuvre. Now, not all spirometers can measure this slow VC. So depending on the equipment available and where you've gone to, you may only be needing to do the forced effort. So your lung condition and spirometry. So depending on your lung condition, the spirometry results can be split into multiple different diagnostic patterns. The most common patterns are classified as normal, where there is no airflow limitation seen, or that can be identified. So that's, for example, patients without any known respiratory issues, or even some well-known or well-controlled asthmatics. Then there is an obstructive pattern, which is a limitation with the patient's ability to blow out quickly. So you determine this from that reduced FEV1 FVC ratio mentioned previous, and with the severity classified by the FEV1 obtained. And this is the most commonly seen in patients with COPD and bronchiectasis. There is also a restrictive pattern, which is seen when the lung itself is reduced, the lung size is reduced to what is expected. So spirometry generally demonstrates a reduction in both their FEV1 and FVC. There are various different reasons that could potentially cause this, some being obesity, for example, and others being lung fibrosis. You can also get a mixed pattern, which is a combination of both obstructive and restrictive. And this is commonly seen in patients with multiple diagnoses like asthma and obesity, or COPD and asbestosis, for example. But for this webinar, we'll focus on the role spirometry has for COPD and bronchiectasis. So before we get into different lung conditions, I briefly wanted to go over how lungs work in general. So when you breathe, air is carried into your lungs through your airways called bronchi. The bronchi then divide again and again into thousands of smaller airways called bronchioles. These bronchioles continue to divide further into small air sacs that contain alveoli. These alveoli have the primary role of allowing for gas exchange in the lungs, where oxygen is able to be absorbed into the blood, while also allowing for carbon dioxide to be breathed back out again. The airways are lined by muscle and elastic tissue that pulls on the airways to keep them open. Inside the small airways, you have glands that produce small amounts of mucus, which enables your airways to remain moist and has the ability to trap any dust and germs that get breathed in. You then find that this mucus is then moved up the airways by tiny little hairs called cilia that promote it towards the throat that keeps your lung healthy and clean. Now, with an understanding of how lungs work, I'm going to give a brief rundown for both COPD and bronchiectasis. Now, COPD, which is chronic obstructive pulmonary disease, is an umbrella term for a group of lung conditions including emphysema, chronic bronchitis, and chronic asthma. Generally, the lungs of patients with COPD have narrow bronchial tubes, resulting from the change in shape from inflammation and damaged elastic tissue, and the potential for their airways to become clogged with mucus. In addition, the alveoli themselves break down, forming fewer but larger alveoli. These larger alveoli make it difficult for gas exchange, as the lungs are not being able to absorb as much oxygen, and also in return struggles to get rid of carbon dioxide from the body. If this airways disease or this airway change progresses, then you can find that the bronchial tubes themselves can narrow further, which can later result in air getting trapped in the lung. This can cause COPD patients to feel more breathless and make breathing more difficult. So with bronchiectasis, the airways themselves become larger as a result of acute and chronic inflammation and infection. So these infections affect the lung's ability to drain secretions and promotes that greater mucus production. This results in itself in further damage, which begins to affect the airways structure themselves and promotes a irreversible widening of the larger airways. So it's this never-ending cycle. With the widening of the airways, mucus begins to pool, thereby promoting further airway damage and then increasing the likelihood of recurrent infections. So, with all that in mind, it's important to note that spirometry is rarely, if ever, used as a diagnostic tool by itself. As mentioned earlier, spirometry provides a pattern of your lung function that, when included with your patient history and other clinical assessments, will influence your healthcare professional's decision towards a diagnosis. For bronchiectasis, spirometry is an important tool in patient management to assess respiratory impairment, as a high-resolution CT scan is generally considered the gold standard and main way for diagnosing bronchiectasis. For patients with COPD, spirometry itself is considered the gold standard, as spirometry results are there to confirm a patient's history, for example, significant smoking history or persistent shortness of breath. Detecting for airflow limitation is extremely important, as some patients that have mild to moderate airflow obstruction may not notice any breathing impairment. Over time, patients may find it more difficult to exert themselves, as they may need to take more breaths to complete activities of daily living. So spirometry plays an important role in the early identification of airway disease and can affect disease progression. In addition, spirometry can also guide both therapy for both COPD and bronchiectasis, as it can provide valuable information by monitoring medication compliance and effectiveness, while also identifying any flare-ups that may need further treatment. So, with all that in mind, what exactly do you need to do before going for your spirometry test? Well, in the hour leading up to your test, we generally recommend that you avoid smoking, vaping, and performing vigorous exercise, as this can affect your results. Also, if you have been feeling unwell, experiencing any chest pain or had any surgery in the last 4 weeks, it is recommended that you inform the staff prior to arriving, as they may wait until those issues have resolved. It is important to highlight that if you have been recently diagnosed with a viral illness, or if you are currently displaying symptoms, that you contact the staff completing your test, as reducing the risk of infection is of the utmost importance. As a result, you may also be asked to undertake appropriate hand hygiene measures prior to completing spirometry to minimise any potential infection spread. The decision to withhold any inhalers before testing should be determined by your referring healthcare professional. If the reason for performing spirometry is to diagnose a lung condition, like COPD, then withholding prior to testing is beneficial. For a test to assess current medication benefits, then generally you would just continue your medication regime as planned. So, in theory, unless you've been specified by a GP or specialist, you don't need to withhold your inhalers. However, if you are uncertain, best just to make sure. So, after you've arrived for your spirometry test, the healthcare professional completing your test will obtain some details from you. It will measure your height and weight and confirm your sex and date of birth. This is all important for when we compare your results to a set of predicted results calculated based off your personal details. These predicted values have been calculated from a general population in the absence of symptoms or lung disease. These details are extremely important for the comparison of your results. Height is important, as generally taller people will have larger lungs. Age is another important factor, as lung function itself peaks around the age of 25 or in your early 20s, then begins to decline thereafter. Sex is also incredibly important, as males do tend to have larger lungs than females of the same age and height. And then finally, there's also patient ethnicity is another factor that's taken into consideration when determining predicted values. So after the healthcare professional has entered your details into the spirometer, the staff performing the test will have you sit in a nice, secure, firm chair, preferably with armrests, and sitting with good posture, with your chin at about 90 degrees to your neck. Good posture is important for completing spirometry, as leaning forward or slouching backwards can impair the results obtained. It's also not overly comfortable. The staff should also provide you with a nose peg and the spirometer set up with a disposable mouthpiece. A nose peg is important, even though it is uncomfortable, as it makes sure that all the air goes through the mouthpiece. Otherwise, any air entering or leaving through your nose can reduce your results and make the test inaccurate. In addition, if you require supplemental oxygen for the test, then you may be asked to remove your nasal prongs for the duration of the test. However, this can become distressing for some patients. So if you feel uncomfortable or unable to come off any supplemental oxygen, please advise the staff. So depending on where you complete your spirometry, at either your GP's or at your specialist clinic, the equipment can vary a lot, as they all come in different shapes and sizes. Some devices can be quite small and can fit in your palm of your hand. However, some spirometers can be more complex and can be attached to a small desk and involving a telephone box style booth. The smaller devices may only record the forced manoeuvre, while the larger equipment, primarily seen in specialists and at hospitals, will be able to complete additional tests to measure your lung function. Overall, spirometry does take between 10 to 20 minutes to complete. However, this may take longer if it includes measuring airway responsiveness or if you're having additional lung function tests done. So, moving on to completing the test. So, once the staff have set up the device for testing, they will then instruct you how to complete the test accurately. The test instructions can vary depending on the equipment available. As mentioned before, you may be told to complete a few normal breaths through the spirometer, then take the deepest breath in you can before blasting all the air out as forcefully as possible and for as long as possible. Some devices may ask you to just take the deep breath in and blow out straight away. Either way, the deep breath in and forceful blast out is the same. Okay. Now, for your test to meet the acceptability criteria provided by governing organisations, the staff completing the test will ask you to repeat the test a few times, ideally around 3. Your highest recorded value is used as the final result. Now, depending on the quality of each test, you may need to do more than 3. So the staff member involved with your test will provide technique feedback if required. From my personal experience, the most common feedback for improving patient technique is minimising patient hesitation after taking the deep breath in. Occasionally when you take that deep breath in, you may naturally just want to hold your breath. And for this test, we just want you to blow out straight away. So that's an easy fix. And also if you just blow out a little bit too slowly. So we want you to be a real fast, forced effort, and that gives us the most accurate results for you. Now, as mentioned before, some spirometers don't measure the slow vital capacity, as they don't have the capability to measure it. It is slightly different to the forced effort discussed earlier. This measurement is completed in a relaxed manner, where we get you to take a few normal breaths. You blow all the air out of your lungs first until you're empty, and then take a really deep breath back in again, and then blow all the way back out. This technique can be reversed if needed. However, like that forced effort, we'll get you to repeat it about 3 times, just to make sure you get your best results. Now, depending on your referral from your physician, you may be given an inhaler to measure your airway responsiveness after you've completed your initial spirometry. Depending on your location, the respiratory scientist or nurse may administer a short-acting beta-2 agonist inhaler. Commonly, that's either Ventolin, Asmol, or Bricanol. However, this could vary. The role of administering the inhaler during spirometry is to assess if, by relaxing the smooth muscle in the airways, does this reduce airway inflammation? And then does that improve your lung function? So after you've been administered with an inhaler, we would then get you to wait for around 10 minutes before repeating the test again. So, as mentioned earlier, spirometry normally takes around 10 to 20 minutes to complete. However, may take longer if we give you Ventolin, or if you have more complex tests needed. So if you have been sent for a lung function test or for spirometry, just make sure that you leave enough time to complete the test, as it can take longer if there are multiple tests to be completed. It is also important to note that for some patients, spirometry will not just be a one-off test. Depending on the outcome of your initial visit and the treatment and management pathway your doctor is taking, you may be asked to complete spirometry on a regular basis to track your health outcomes. So I've included a slide on common responses from patients that I see here in clinic. Patients often report feeling short of breath during the test. This does happen as you're trying to empty your lungs out as quickly as possible. Patients may begin to feel short of breath after a few seconds and just don't feel like there's any air left. In the majority of these cases, the spirometer is still actually measuring airflow, and you will be encouraged to continue for as long as you can. You won't be completing the tests one after another, so you can take time to have a break if you actually need. Occasionally, these tests can make you feel lightheaded or dizzy. This normally happens towards the end of the test. If it is to happen, it generally happens towards the end of each effort and doesn't last too long. If you do experience any dizziness during the test, the staff member normally notices. However, also let the staff member performing the test know, so you have a little bit of time to recover. Another comment that I hear often is that this is not generally how you would breathe. That is true. However, for the staff and the doctors to get an accurate understanding of your lung function, we will need to measure your lung function at its maximal capacities that you can provide us. By providing staff with your best effort, then the staff can then in return provide your treating healthcare professional with accurate and reliable data of your lung health. Another factor to consider is that you may cough during the test. Certainly, coughing is uncomfortable. However, the staff involved will do their best to minimise the effect coughing has on the test. Occasionally, your throat can get dry from testing, so water can be provided if required. So you've completed your spirometry test and the staff member is happy with the result provided. What happens next? Well, your results initially are tabulated next to the predicted value and the lower limit of normal mentioned earlier, which are based off your age, height, sex, and ethnicity. In the majority of cases, any underlying airway impairment or pathology will provide lower results for parameters of spirometry than that is predicted for you. The main parameters that are assessed by your GP specialist, as mentioned before, are the FEV1, FVC, that forced, or that VC, the FEV1 over FVC ratio. Now, thanks to modern engineering and computer programming, your results are available almost immediately after the test. This allows for minimal delay between the completion of the test, which is reviewing of the results by your GP or specialist. Depending on the spirometer and the compatible software, your forced efforts are displayed in two different graphs that are useful in the interpretation of your results. Now, as you can see on the screen, the top graph itself shows the peak expiratory flow and inspiratory flow loop when breathing maximally in and out, while that bottom graph displays the amount of air blown out against time. So it gives us a good understanding of how functional your airways are. So in patients with COPD and bronchiectasis, the graphs obtained can be a little bit different to what is expected. When compared to a normal expected flow volume curve, you can see that there is some scalloping as seen on the image to the right-hand side of the screen. Now, generally, COPD and bronchiectasis patients display that kind of pattern, and that is what we determine, or what we call an obstructive airways pattern. Airway obstruction is determined by a reduced FEV1-FVC ratio, with the airways experiencing dynamic airway compression during forceful expiration. That does not allow, so that in result does not allow for air to flow out as quickly as expected. So to think about it in a different way, it's like having a 4-lane highway that has been reduced to 2 lanes due to roadworks during peak hour traffic. The traffic takes longer to get through that stretch of highway. So if you think about it, same way with your airways, if your airways are narrower than normal, it will take you longer to empty your lungs of that air. As a result, the peak speed can be reduced, and the FEV1 has decreased due to the airway damage caused by the compression. The total volume of air blown out may be comparable to normal, however, can vary depending on disease severity. With that in mind, it is the actual reduction in FEV1 when compared to the total volume that we determine the obstructive airway pattern mentioned. So with obstructive airways disease, the level of severity is based off the reduction of your FEV1 when compared to what is normal for you, or predicted for you, sorry. The severity classification ranges from normal to mild, moderate, all the way through to very severe. So if the airways disease progresses, or if you experience a flare-up or an exacerbation in your condition, and depending on your FEV1, the classification of airway obstruction can change from a mild obstructive pattern to potentially a moderately severe airway pattern. This classification will assist your healthcare professional in determining your medical pathway for treatment and management of some treatment options depending on your classification grading. So, to summarise, spirometry is an important test that assists with the diagnosis and treatment plan for managing your lung health. That concludes my component of the presentation today. I do hope you've been able to learn something new regarding spirometry and why it is involved in your healthcare management. Please send through any questions and I'll do my best to answer them at the end.
Great, thank you so much, Ian, for taking the time to share that with us. It's been fantastic, I think, for people to have a thorough understanding about spirometry, and hopefully everyone was able to also take the time to think about any questions that they may have, and then we can share those with you and Amanda at the end as well. So that does bring us to Amanda. So what I'll do is now introduce Amanda, our respiratory care nurse, if you would like to say hello to everyone and have a bit of a chat about your role here at Lung Foundation.
Thanks so much, Chanel. Hi, everybody, and welcome to the webinar today. My name is Amanda, and I'm the respiratory care nurse here at Lung Foundation Australia. Part of the role that I run is the respiratory care nurse program, which is currently running at the moment, Tuesday to Friday. Part of the importance of this role is that you can self-refer into the role by calling our information and support number, and it's a free confidential telephone service that we run. Over the 3-call program that's offered to you, which will go over about a 4-month period, part of that is allows a discussion to learn about your diagnosis of either COPD or bronchiectasis, and to gather lots of information on your lead up to your diagnosis, your current management, and then to be able to offer support through education, resources and information to support you on that journey of self-management, to improve your quality of life living with a chronic lung condition. The 3 Call program, as I said, is confidential. The program is for people with COPD and bronchiectasis. And part of the information and how it relates to spirometry is part of the question during the telephone appointment is that we ask you when your most recent spirometry test was. The importance of that, and what I've noticed in the majority of calls, is part of the question is to ask patients, are they aware of their most recent results from their most recent spirometry test? And the majority of the time, a lot of patients aren't able to explain to me during the telephone appointment about their results and what the test results showed, or their understanding of what it means for their current condition. So part of what we go through is we ask whether or not, and this relates back to Ian's discussion on the results, I'll ask you whether or not you are aware whether the results showed that you have mild, moderate or severe severity of your COPD, and also maybe whether or not the doctor's informed you of your FEV1 percentage. So I will always advocate for people to be able to know how to go back and ask their doctor, but the most important thing about understanding your test results is ask your doctor to explain it in terms that you understand and what it means for your current condition, and in particular, your ongoing management and recommended treatment options, depending on whether you are in the mild, moderate or severe category. For people with bronchiectasis, we also ask if they've had a recent spirometry test, as that's part of sort of routine workup at the time you are being given the diagnosis to determine your lung condition diagnosis. And also importantly, the spirometry test is done to ascertain whether or not you have another dual diagnosis such as asthma COPD or COPD alone. Then that way we target the education and resources and information for both single conditions, both bronchiectasis and COPD. The other interesting part at the moment, obviously, is with coronavirus, is that there's been a suspension in spirometry testing, which is most commonly performed in general practice or medical centres with your GP. At the moment, we're guided by the Thoracic Society of Australia and New Zealand in regards to these tests being performed again back in primary care. So when I speak to patients, the most common thing I ask is, when was your last spirometry test? So if a patient said that it was many, many years ago, what we're currently advising is to ask your medical centre or your GP what provisions they have in place at the moment to either carry out the spirometry test and recommence the testing. But I would advise, if there was going to be a long continuous delay in spirometry testing being available in general practice, that you discuss with your GP around the possibility of getting a referral either to a specialist or to a hospital setting like where Ian works, for the possibility of the test to be performed in a respiratory science lab with a respiratory scientist, just so that there's no delay in testing available to you. If anybody on the webinar today, if you're either currently going through your diagnosis, you need to go back and ask the doctor for a spirometry test to gain a diagnosis. But most importantly, for people living currently with bronchiectasis or COPD, who haven't been able to tap into our free service and be supported with resources and information, certainly give us a call, and you can contact the information and support team and organise an appointment with myself. And I look forward to hearing from you. Thanks so much.
Wonderful. Thank you, Amanda. It's wonderful that people could put a face to the name and see who you are before they ring and make an appointment to have a chat with you. So we now are at the Q&A section of the webinar. So I can see that we have a few questions already. Now, what I'll do as well is just remind you that these any responses to your questions will be of a general nature only, and obviously, you know, to check in with your GP or treating healthcare professional as well. So what I'll do is I'll open up. So the first question actually comes from someone who's living with an ILD and has said that completing a spirometry test can actually be very difficult without coughing, Do you have any tips for how to avoid these triggers? Hand over to you first, Ian, and then perhaps Amanda, if you had any insight as well that you might like to share, and see if you're able to provide any guidance here.
So with patients with ILD, it's pretty much a case-by-case basis. Some patients have their own pretty much rituals before they come in. They might do a few clearing coughs, or they might have a lozenge. However, that's their own preference. Depending on what kind of condition that they're in, even if they are coughing, we can still complete the tests. I know from the experience that I've had working in an ILD clinic, patients that have that they cough very frequently. I've been able to work out a way of getting their technique so they can get the best effort that we can from them. So even if they have been coughing a lot, if they cough during the test, we can still work around what we've been able to achieve, then pass the results on to your specialist. Sometimes the coughing could just be, it could be quite too frequent. We may not be able to complete the test, but unfortunately I don't have any surefire ways to stop the coughing, but normally the respiratory scientist completing the tests hopefully is able to change the technique in a way which is then able to get some reliable and acceptable results from you.
Great, thank you, Ian, and hopefully that was able to provide some guidance for the person who asked that question. And we'll go through to the next question, actually. Someone has said that they have completed around 10 spirometry tests. The results actually suggest that they have stabilised.
Mm-hmm.
Are you able to shed any light onto what stabilised means? Ian, I'll hand over to you.
So thank you. So with that question, so if, for example, they've stabilised, so what that normally means is the values that we've been measuring have been relatively stable. They haven't progressed, or they haven't dropped down further. So they've sort of been holding their own over the more frequent visits. Now this could be from certain medication, or you could be your adherence to the medication could be excellent, and they've found the right one for you. So you've been able to maintain what or what lung function that you have got. So that's normally what they mean by stable, that your lung function hasn't decreased or hasn't declined between visits. So yeah, with stable lung function, it often is either your airway is you've got no exacerbations, or you're not feeling unwell, or they've found the right level of medication adherence for you to promote that stability.
Great, thank you for that. The next question, we've got quite a few coming through now, which is great. So thank you so much, everyone. The next question is around exercise to improve lung function and strengthening those muscles around the lungs. I'm wondering, Amanda, if we'll throw to you for this one, if you're able to provide any information there.
Thanks so much, Chanel. That's a really good question. I will just give a brief answer, and Ian, I'm more than happy for you also to join on this from a scientific perspective as well. So physical activity plays an important role overall in people's lung function, in the sense that deconditioning occurs quite quickly due to breathlessness. So people err on the side of caution of continuing to be physically active because of the breathlessness that it causes. Part of pulmonary rehabilitation, which is a dedicated education and exercise program for people with a lung condition, regardless of the severity, includes specific physical activity exercises around strength exercises for your upper body, to really look at that ability of our big muscle masses to carry and support our chest area, not only for the purpose of learning how to effectively breathe, but also most importantly for the clearance of mucus and secretions, which is a very physical act. So for breathlessness not to get worse, for quality of life, in being able to actually continue with a regular regimen of physical activity plays a really important role in establishing someone's ability to cope with ongoing everyday breathlessness.
No, that's pretty much all I was going to say to Amanda. So that's I've got nothing else to add there. It's good.
Okay, great. Thank you for that thorough response, Amanda, and I hope that that was able to provide some guidance to the person who asked. Now, we do actually have a question in relation to using ventilators before a test. So this individual has said that they've been advised not to use ventilators before the test, and just wanting to get a bit more information around that. And as I said, the information that we're providing today is of a general nature, but I'm just wondering, Ian, if you're able to touch on that area of using ventilators before the test or not. If you're able to shed any information on that again, thank you.
Sure. So I imagine it's maybe Ventolin or other bronchodilators that you're referring to. So with Ventolin, if you have, as it's a very short-acting medication, it can, so with it being a short-acting medication, it can give your airways or improve your lung function to a degree, which if you were to then complete spirometry with, and then we were to give you bronchodilators again, so give you Ventolin again, we may not see any change there. So it may just mask any potential improvement with, if you've had your inhalers prior. In saying that, if you take, say, Spiriva, or if you take a different type of inhaler, then that in itself doesn't overly affect the results. It's mainly that short-acting, the Ventolin or the Asmol or the Bricanol, which can be sometimes you get asked to withhold it. But it's primarily, if you are asked to withhold your those type of inhalers, it's primarily just to see what kind of response you do get to it, and is it still useful for you? Because sometimes it may not, you may be taking it a bit too much and it may not be needed, but that's always for the respiratory nurse or the doctors to determine that.
Okay, thank you for that, Ian, and providing that clarification. So we actually have another question, and this time it's around someone who's going through the process of diagnosis. So they've been advised by a specialist that they may have pulmonary fibrosis, and their question is spirometry beneficial in helping with PF diagnosis, or is it specific to COPD and bronchiectasis? Again, are you able to provide any insight into this?
Yes, I can. So with the diagnosis of pulmonary fibrosis, spirometry is a very common test for the patients we see that come through the hospital with IPF. Commonly, we'll get you to do the spirometry that we've discussed during this webinar. And then we'll also get you to do a few other tests that we haven't divulged today. They look at the diffusion of oxygen across the airways, and then also we will then measure your overall lung size. I don't know if you remember back, there's a picture of that box, and I should describe different spirometers, but in there you can measure lung volume. So spirometry is extremely relevant for IPF, and it's one of the major tools for when some patients, if they're getting listed for certain medications, it needs some of those spirometry values to meet a certain criteria before it can be approved. So spirometry is definitely an important component for treatment and management of IPF, but there are additional tests as well which are routinely completed.
We do have, I think we have time for one more question. So we'll just have a look here and see. I think another one has come in, and I'll invite both Ian and Amanda to provide any insights if they would like to. Perhaps first we can go through to Ian and then Amanda. The question is, can becoming stronger and fitter through exercise improve spirometry results? Ian, if I can hand over to you, if you've got any insight.
Unfortunately, with your airways, they naturally decline after about the age of 25. So even myself, my airway function is declining as it is. With exercise, your lung function might help you clear some potential mucus or any osputum that you may have in your airways, which may improve your symptomatic feeling. However, quite commonly, you don't tend to see a large improvement. If you've already got airway damage, It isn't a reversible condition. So if you've got airway damage, becoming good exercise is excellent, and it's definitely recommended if you're able to do it. But the effects that exercise has on the respiratory system, it's more of it's a bit limited. It's more of the muscles becoming better adaptive to using oxygen, so you don't need to use as much. That sort of works on a bit further down the track than just the lungs themselves. So with exercise, you can't necessarily always improve your lung function if it's airway damaged.
Thanks, Ian, for answering that. I don't have anything specific extra to add to that. I think that was a great answer. So thanks, Ian.
Great. Well, thank you to both of you. That's actually, we've come to the conclusion of the webinar for today. So thank you to Ian and to Amanda for taking the time to join us today and share your knowledge and insights. And I hope that everyone listening was able to gain something out of the webinar and feel more informed. Now, if anyone does want to find out more, please know that you can call our Information and Support Centre. You can call us, your family or loved ones, if you have any questions around managing your lung health. And we can also book you in to speak with Amanda, our respiratory care nurse. So thank you again for joining and coming together online. That's all for now. So please take care of yourself and each other, and we'll see you next time. Thank you.